My name is Ying Hui Su. You can just call me Su. Dr. Su is okay. Yes, Dr. Su is okay. And I'm from Taiwan. And today I'm going to talk about the endodontic field, about the 3D guide, which is 3D printing, and the navigation system, and a little bit about the AI-driven CBCT segmentation. Yes. So let's begin with my country. I'm from Taiwan, and our famous thing is TSMC. If you know that, it's a Taiwan semiconductor manufacturer company, which manufactures semiconductor. Semiconductor, like your cell phone or your computer is with semiconductor inside. And the famous food of our country is bubble tea. Yes, and maybe you can see a lot of this. And here is Taiwan. We are next to China. And okay, and here is the hospital I work in. And this is my experience in education. I have my MS degree in Taiwan, and also I am the endodontic specialist in Taiwan. And I have different experience using the different CBCT and 3D printer, oral scanner, and different navigation system. And also I use different kind of software to produce my case. And also I have my YouTube channel here. It's including some of my speech inside my YouTube channel. Okay, and before beginning, of course, the first time I came to Asia, I went to the Kong Temple 3 days ago, and the guide said, "Oh, you look, this one is the surgical instrumentation in the past. They carved this on the wall of this temple." And I find they told me that this one is the forceps, the tooth extraction process. I don't believe it, but I went back and I find a paper here. I find a paper, yeah, it is a tooth forceps. Originally, I think he is shitting me. Yeah, yeah, but I don't believe it. But yes, I find something I can believe. Yes. So this is my today outline. There will be 4 parts of this. The first part will be reasoning. We use the 3D guided navigation system in endodontic. That means why we should use it. And the second part will be some introduction of 3D guide and the digital navigation system, the principle of this. And the third part will be clinical cases. That is my case. And the fourth part will be a little bit artificial intelligence and the future outlook of endodontic treatment. So let's begin with the first part. So this is which we are very familiar with the endodontic treatment, the traditional way. We use high speed, we use skeleton drill, and we use file to scout the canal to try to establish the straight line access. And nowadays, we have a lot of different kind of technique. Like we use microscope, we use ultrasonic device, and of course we use the CBCT. And a lot of different kind of different brand of rotary system. And also we are trying to get more small access as small as practical, not as small as possible. It's as small as practical. So maybe the red one, this is maybe too small, and the purple one is maybe too big. So maybe it's in the middle, like the green one. It's conservative, but maybe not ninja. And this is nowadays we try to do the endodontic in different way, which we can do some conservative access, or we do the caries access or restoration access. That means if there is original, there is a hole in there, you can try to access the root canal in that way. and also the anterior tooth. And we also know that if we do the root canal treatment failure, or we do the or it is impossible to do the retreatment, we will do the apical surgery. Yeah, and this is the apical surgery that we very well-known Dr. Kim in Japan, and he say that maybe 3 mm card and with retrograde fitting. With retrograde preparation with ultrasonic tip, and do the retrograde preparation, retrograde filling with any kind of calcium silicate cement, any kind of it. But all this is the modern endodontic treatment we know. But sometimes if we meet some difficult cases, maybe we will get lost. Like the case here. This is a retreatment. I remove the crown, but I take the CBCT and I cannot find canal in this area. Or when we are trying to do this apical surgery here, and after we reflect the flap, there is no dehiscency or penetration in this root. So we have some difficulty to find the apical area. Then sometimes we get lost. And when we get lost, we will count out something like knowing the different kind of root canal anatomy, which maybe there is a mesial-buccal canal, mesial-buccal tooth canal, or there is a different distal lingual canal in lower molar. Then this is we have to know this kind of different anatomy, and sometimes we will look the dentinal map under the microscope. Like if you do the endodontic a lot, you will know this picture. You didn't remove the pump. You didn't remove the roof. You didn't reach the top floor. And if you see this in microscope, you will assume that maybe you can find the MB2 canal here. And you will read this dentinal map and try to reach the palatal canal, maybe right here. That is when you get lost, you read the dentinal map. And another, you will use your clinical experience to try to find the tooth axis of your preparation. If you still remember that the first time you did the endodontic treatment, you will do like this. The red one is a little bit not correct, and the green one is correct. But that is what you are looking when you drill in patient mouth. It's a lot of it. You need some experience to do this. And also, we can take CBCT to find the root canal like this one. But when we look the CBCT, we speculate it. We imagine that in your mind, like this case. This case is here is the calcification here. The canal is obliteration calcified on the middle part, but still got canal at apical part. So that's difficult that if you take this CBCT and you still not really know where you have to go, you will assume you will image this picture in your mind, but you see that and patient here, you still not very sure where you are going. Like you will assume I'm going to a little bit mesial or a little bit distal, but you still try to image that in your mind. So that's what I'm going to say. That if you have CBCT, that means like you have a map. But everybody knows if you have map, you still can get lost. That's what this picture means. You have CBCT, but sometimes you are not very clear to know that where are you going. So that's where navigation should come in. The navigation shows the way. So this is my opinion of this thing. the CBCT gives us the map, and the experience fill the gap. You see the CBCT and you try to use your experience to find the canal. And if that is not enough, the guide and navigation is the way. Yeah, so that's where the navigation system comes in. And so here is the second part, will be the 3D guide and digital navigation. So I don't know if any of you doing the restoration or orthodontic or single crown bridge. If you are doing this, you can know that we have a lot of digital tool that we can use. There is maybe you want to do this crown, you will use the oral scanner to scan your tooth in reality and transform the data of reality into digital world. And you will do some digital design here and use the CAD machine or 3D printer. Use the CAD machine to put your design back to reality. That's a circle. Okay, so when we do the endodontic treatment or the apical surgery, we got some difficulty. We will do like this, like the guided implant placement, which has been done maybe more than 20 years. So it's this one is an early published paper. It's a 2016. It's a guided endodontic treatment, and the concept is all totally the same with the guided implant placement. So in my opinion, that's I call this digital endodontics. We have reality, that means you have bone structure and your root canal system. We take CBCT and oral scanner, this oral scan, to transform this data from reality to digital. And after we've done some planning in the software, we use the navigation system and the 3D print guide to put this data back to reality, and that's the circle. Okay? So let's see a little bit some principle of this kind of tool, like the CBCT. If you know, you understand the CBCT, you will know that the CBCT is when you take the CBCT, it will give you a box. Like 100 plus 100 plus 100, one box. And within this box, there is a lot of pixels inside, and every pixel represents a number, which like, if you see this, this here, you will find if there is air, is 0. And maybe if there is skin, your soft tissue will be 250, and maybe it comes to the bone, it will be 1,000. And all of this is just a number of this CBCT box. And if you use oral scan, you will find it is a camera inside the oral scanner, and it uses this mass, this equation here, to make it has two different cameras and capture one single point and try to calculate where is this point. And after this equation and this software calculating, it will transform your tooth into a lot of points. That's so-called point cloud. There's a lot of points in your computer. Okay, so it's also the same with navigation system. If you can see that, it's the same equation of this one. It's a math. Yes. So in navigation system, they have two different camera here, and also they calculate the different distance between the camera and the tracker. So that's the way you put the digital information back to reality. And also, we have this 3D printer. You design your guide plate and in 3D in software, and you use the 3D printer to print this tooth out. Okay. So if you are not very clear of this concept, let's see the clinical cases. They will be more clear that you will get the point. So this is my clinical case. First one is I use the 3D guide to correcting the direction error which occurs by our resident doctor. So here is the tools that mesiolingual and mesiobuccal canal is configuration, which is not very easy to find. It's with our resident doctor. So if you can see this reconstruction of CBCT, you can see he tried to get to the root canal, but the root canal is still at the very bottom of this tooth. And as you can see, the direction is going in the wrong way. It's already going the wrong way. But this resident is very smart, and she still can understand that she is going to perforate it. But she stopped and come to me, so we take a CBCT and we do this reconstruction to evaluate. And after this, we do a 3D print treatment planning. That means this is the two drill pass. I am going to drill through this and do this is the drill pass here. We try to penetrate the obliteration at the middle of the root. These two grains in the center is the pass. So because this resident didn't use this before, so I print all this in 3D print model, which I print in here. If you would like to see, I put it here, and please don't break it. And so we do this and do this 3D model, and this is what it prints out. And as you can see, I cut it into half. This is the wrong direction, and this is the true canal here. And we do the virtual surgery before we actually do in the patient mouth. I use this kind of Muse discovery curve. And this is the intraoral trying. And this is a video. And this is finished in 2019, 2021, I think. So at that time, I am not very familiar with this this technique, so I didn't use the rubber then. But after this, after we find the root canal, we use the rubber then after all the endodontic treatment. Yes, and this is just a procedure that I'm going to do, and and this is after I drill using the guide. And as you can see, the more black one is true path that I drill through, and the white one is the wrong path. Okay, so I put this together like this, and this is our virtual tools, which this tool is wrong path, and this two small one is actual mid pass. Okay, so we finish the root canal treatment. After we find all the canal, we use rubber dam. We always use rubber dam. Okay, and this is the post-operative. As you can see, because the treatment course is very long, so even after we finish it, I think this is the COVID time. We almost finish before we find the root canal, and it's COVID time, so patient didn't come back. And after patient come back, it's maybe 1 or 2 years. So the lesion is almost healed after we feel it. And then the first one, and this is the second one. We use the 3D guide to do the retreatment. And this is these tools, and patients have some symptom sign, and we do the sinus GP tracing. Okay, so we decide to do we remove the crown and do the endodontic retreatment. but we encounter the mediolingual canal obliteration. So as the first case, we do the treatment planning with the 3D software, and this green circle here is we trying to locate the mediolingual canal. Okay, and the other different color is the soft tissue and the tight plate. Also, this is the path we try to get to the mediolingual canal. And this is the 3D print guide we are going to make. And this is the different direction view. And I also do the reconstruction of this CBCT using the 3D slicer, which is sponsored by the American National. It's an open source software. Yes. Okay. So I print it out, and I also use this kind of Muse discovery firm to penetrate the calcification. Okay. So this is before I use the guide plate. This is after I use the guide plate and the mediolingual area here. Okay, so I locate all the canal and I remove the old filling material. And we do the mescal try-in and root canal feeding. And I try to put this very big. So as you can see, this is the mediolingual canal, and you can see here is more radial opacity because that is the drill path I'm trying to get into. So I draw in a red line for this, and you can compare this. Okay, so I filled it with the gamma percha. And this is a 2 years follow-up, and new crown is on it, and the ample region is almost healed. Okay, and I also published one of this paper in 2021. And this is about the guided endodontic accuracy of anterior tooth and posterior tooth. And this is a paper I just did a lot of tools and try to get this thread. And as you can see, the accuracy in the anterior tooth and the premolar is better than the molar. And if you want to find, you can find this paper. Okay, so I move on. And the next one is the navigation for the canal obliteration. So this one is a very interesting case because the patient is followed in our perio department. So I have all this almost 8-year follow-up. When it is 2014, you can see this is a big amalgam field, and you can still see some canal space here. But after very long time follow-up, you can see the amalgam is not very intact because it is too big and the time is very long. So you can see is some decay on the amalgam, and as you can see, the root canal, the pulp chamfer image is becoming more and more not very clear. So and in this time, patient complains about the soreness of his tooth. Okay, so he tried to get this off, so he come to us and we try to do the endodontic treatment on this tooth. So this is the previous image of this tooth. So after I try to open, I cannot find the root canal. So as you and I am I do a lot of endodontics, so I know I should stop right here. And I stop and I put APEC, which is yellow here. I put the APEC and I send patient to take a CBCT. So you can see I am almost perforating. It's maybe less than 1 millimeter, but I stop. Yeah, lucky. So but that means my direction, my axis of this tooth is maybe is right, but it's a C-shaped root canal and got some calcification. So my direction is not very wrong, but I almost perforated at the furcation here. So I plan with these two blue cylinder here to try to locate the C-shaped root canal here. Okay. So this is the image that I actually do in the calcification. I actually do in the dynamic navigation. As you can see, here is I try to get into the mesiolingual canal here, and this is X side, which is called maybe X navy in different country. And I try to get into the mesiolingual part of these tools. And here is the procedure I'm doing. And when you, as you can see, when you reach the proper depth, it will become from green color to red color. That means you over your planning area. Okay. So I finished the root canal treatment. This is the C-shaped root canal, and I got a 6 month follow-up. And here is some video that I put in synchronized with the microscope and the navigation system. And the navigation system, because you do not need a plane, so it's easier for this to use the rubber dam. It's easier to use this. Okay, but I'm not going to run all over this video. And this shows that if you touch some tracker of your navigation system, it moves and you have to recalibrate. But you can just remove part of the rubber dam and try to redo the registration here. Okay? If anyone has question, I can answer that. Okay, we go on, and we get to the fourth case of this. We use the 3D guide for locating the apical area, which means it's apical surgery. This is the case. Obvious, it's not very long post, so this patient got symptom. So we decided to do the retreatment first. So we remove the crown, remove the post, and we do the root canal treatment. And of course, we found a missing canal here. It's a two canal lower premolar. Yes, and we remove all the GP and try to get it right to fill these tubes, the two canals, and a little bit sealer extrusion. But after this, patient still complains about the tightness of this. So we decided to do the apical surgery. And I planned this with 3D slicer, and here is the oral scan and the bone service. And I mixed the oral scan tools and the CBCT bone service together to make a model. And I do this like right here. As you can see here, the yellow, the red line here is with the tool service and the bone service, which means my 3D print guide will attach to the bone service. And here is the 3D print guide. So if I didn't reflect the flat yet, the plate cannot reach the bottom. As you can see, if I put this plate here, and it will put some pressure on the soft tissue. Okay? Yeah, as you can see, and this will be some reference that we design how to put our incision. And here is the 3D print guide. And here is the video that I do the incision. I only got maybe 14 minutes, so I jump to the. Okay, here is I drew the guide. As you can see, I will put the gas here, and I will tell patient to bite. And when patient bites, the plate will be stable. And I can put a retractor here, and the guide will help me to retract the plate. And I remove the bone, and remove the bone plate and remove the apical part of this tooth. As you can see that there is a two GP, two hole of GP, as you can see. Okay, so I do the retrograde preparation, and I put some collagen, collagen here, and just put the bone plate back inside and suture. Okay, here is the before retrograde preparation, and as you can see, it's some isthmus here. So I prep the isthmus also and fill with MTA. Okay, this is the suture, and this is the root part. I removed it, and here is the post-operative. This one I think I have 2 years follow-up. The ankle lesion is almost healed, and we put a new crown on it. Okay, so this is some concept that if we put this is this case, and the blue light is the blue line is the surgical guide, and here is the tree fiber. We try to reach the apical part. And because I work at the hospital, so I use this case to manufacture this 3D print model here, and I try to teach our resident, which I bring the model here. So I print it out and with actual canal at the apical part. And here is our teaching in our hospital. And here is a picture of how we do this 3D print guide and navigation together to make everyone to understand this. Okay, so and another one, if you want to do this apical surgery with piezo, it also works. And it also works in, it was shown in a lot of different papers. And I don't do a lot of explanation of this case. I just use piezo to make a bone window. Like someone will call it bone link technique. That's okay. And oh yes, we can put we can do the surgical guide with a rectangular here and use the piezo to remove the bone and cut the root tip and to do the retrograde feeding. And this one is because no hole. Okay, so this one, not much collection of this one. And we may move to the next one. That we use also the navigation system to do the ankle surgery, which is almost the same concept you doing this with 3D print guide. It's just dynamic. Okay, and this one is this poster is very difficult to remove. Yeah, so we decided to not remove the crown, not remove the post, and do the ankle surgery. But if it is in posterior lower tooth, it will be the buccal bone will be thick, so it will be difficult to penetrate into it and difficult to reach that part. So here we do the software planning. And the different both mesial and distal root. So this is the actual video that I'm trying to reach the ankle third. So as you can see, I looked into the screen rather than the patient. Yes. Here I think. So here is you can see I use tree fiber to remove the bone plate and take the bone plate and put it. We don't have hands solution in our clinic, so we just put it in normal solid. You want to put in hand solution or HPSS, that's fine. That's better. We just don't have that in our clinic. Yes, and we remove the APEC, the root section simultaneously. So I always tell patients to find the trach or find your guide because that makes the tracker more stable. Just find it. And you cannot do this in implant placement. If you do this in interplacement, now you have to make patients to open their mouth. But when you do the apical surgery, you can do this. It's more convenient to do this. And patient will be more comfortable when they find this. And this is the mesial root. As you can see, there is the isthmus, and this is the distal root. So we clean the mesial root, the isthmus, and the distal root. And we fill it with MTA. And this is the bone plate. And after we done all the apical part, we put the bone plate back into it. And this is post-operative. And this, I think, I have 1 year follow-up. Here is the left one is the post-operative, and here is the 1 year follow-up. The vision is still okay. So next one is just next one is also we do the navigation to the apical area. It's just not X-Guy. It's called APEC. It's a Taiwan company. Okay, so this is 2015, which retreat in our hospital. This one is retreat by my teacher. And of course, she removed the crown and removed the pulse and do the retreatment at 2015. But after 10 years, follow, the patient become symptomatic at the apical area. And we check the probing, we check the CT. We don't think it's a vertical root fracture. So to do the surgery, in one way we try to make sure if there is vertical root fracture. That's called exploring surgical. But in this, in the same time, if there is no vertical root fracture, we do the apical surgery, right? Okay, so this is the synchronize of the microscope image and the navigation system. And the Taiwan company, you can see there will be some lag, the computer lag in here. Yes. Okay, so maybe I'll check. Yes, so this is the training procedure of this tooth. Oh, I only got six minutes left. Okay, I jump to here. Okay, and as you can see here, if it becomes the green color, that means you are almost there. And you also can find the angulation and the dips of this when you are treating here. Okay? Okay, so we remove the bone plate and remove the root segment simultaneously. Okay, and we remove the root segment. Okay, in both medial and distal root. And here is the bone window, and here is the retrograde preparation, and here is the anterior filling. Okay, and I personally always put the bone plate back to the cavity. And this is the suture. This is the post-operative, and this is just done last month. And the last one case is the clinical case of a 3D print guide for auto transplantation. And the tools here, 47, is vertical root fracture. So we do the digital treatment planning to transfer third molar to second molar, like this. Okay, so this is where our planning, and we use this 4 drill paths to create the bone cavity for the donor tooth. Okay, so this is the analog and the 3D print guide. And I think I don't have time for this. So I structure the tools and try in and use the the surgical guide to prep the bone cavity and try in the analog. And after finish the try-in of the analog, we transplant the tooth into that cavity. Okay. Okay, this is the tooth and the analog picture. And this is the vertical root fracture. As you can see, we use stent to prove that here is the vertical root fracture. Okay, and this is the post-operating. And we finish the root canal treatment. And here is the 2.5 years follow-up. As you can see, the lesion is healed, and we put the APEC on it. Okay, so we finished the clinical case. So we're going to just a little bit into the artificial intelligence here. In recently, very famous of this different AI is almost the part of deep learning here. And the AI is a more big collection. Yeah, and so like a lot of technology here is in this deep learning algorithm, which you can use this to check to find out is there the diagnosis that is there caries, or you can find if you give some image to it, you can find a lesion of maybe oral cancer or something. And of course, you can do this in CBCT. You can recognize if there is the apical lesion here, or it can try to understand if your apical feeling is correct or incorrect. So it's a deep learning algorithm which calls maybe some UNet or artificial neural network. That is all you can do. Okay, and so the paper shows that it can recognize it's a correct feeling or it's incorrect feeling. And this is the segmentation of this CBCT. It can segment the different tissue, like bone tissue in blue and tooth in yellow, and feeling material in green, and lesion in red. This is all you can do. Of course, there's some commercial software. Here you can segment the tooth and to isolate the different parts like caries or restoration, and to calculate the CEJ and the bone level. And of course, the different software, and also this artificial intelligence can do the set analysis on your volume of your breast, your breast. Okay, and this is also the different software. And personally, this is my research that I do the hand level of these tools and different color you can see. The root and root canal and the bone. So we train our AI model to do this. This is my level, which do by human, and this is prediction, is predict by AI. So this is the outcome. We can produce this 3D model from one second. So this is the outcome of the 3D model. As you can see, the tooth is easier to do, but the root canal is not very good here. As you can see, the root canal is a little bit not very clear. Okay, so this is our outcome. The bone accuracy is 96%, the tooth is 92%, and the canal is only 84%. It's more difficult in root canal. So we try to do the root canal segmentation here. This average is 90%. So of course, we encountered some robotic surgery. And I personally think the robotic surgery is almost the same with the navigation system. Just they add a robotic arm inside it. Yeah, so this is BU, Boston University, the paper from Boston University. Oh, sorry, I think maybe some American knows the Yumi robot. Yes, and this is so they they also use the tree fiber to remove the bone plate and impose the two segment. And here is their material, and I think I don't do this. And personally, I do a lot of this software teaching in past 5 years. But personally, I think I spent 5 years to do a lot of teaching, and I put my teaching on the YouTube. And this book I plan, they do this, they create this software very fast. They can do what I do 5 years in only 5 minutes. So here is the outcome. They do this better than me, a lot. Yes. So I still use their software to. I become to use their software to do my clinical guide. So I think okay. Okay. So here is my conclusion. Here is I use the CBCT and oral scanner and to put the reality information into digital world. And I use the 3D print guide or the navigation system to produce the data from the digital world back to the reality. That's the circle. Okay, so this is my contact. And I don't have my time for this, but I do this. I to try to explain that what tool or time or any advantage and disadvantage using guide navigation system or starting guide here. And here's all my lecture today. Thank you.